The patient, even on probing, does not give any history of past seizures. And we do an MRI, we do blood investigations and an EEG, and we find nothing abnormal on EEG or MRI. First seizure, no obvious provocation, no drugs that could cause seizures. The question is, how do we manage this patient?
Midazolam spray. It's very effective, extremely effective, and so easy. There is the spray with a nozzle. You have to just put the nozzle into the nostril and give 2 puffs. Very easy. Almost everyone can manage. Anti-seizure medications are like paracetamol. All that they are doing is that they are stopping the seizure from happening, just like paracetamol stops the fever from coming. Okay, they are not some hi-fi drug that is going to change the morphology of the brain.
Let me introduce the topic for today. We are discussing epilepsy, or actually, we are more correctly discussing seizures. As you know, not all seizures are epilepsy, and therefore, we'll try to make a distinguishing analysis of what is a seizure and what kind of seizures constitute epilepsy. So, that is our one area that we'll discuss. The second area is, of course, most of us are family physicians or general practitioners, and we will be hoping to learn from Dr. Natasha Nathapnis how to, in our outpatient, how to manage epilepsy, how to diagnose epilepsy, and how to diagnose secondary causes of epilepsy, which especially we are more likely to see. And of course, when do we refer cases of epilepsy to the neurologist, which I would do most of the times, but Dr. Natasha might encourage us to do some primary care before we think of referring. The first question is, I'll take a case straight away. A 27-year-old male adult comes to us with the first ever episode of what looks like a grand mal or a generalized tonic-clonic seizure. The patient, even on probing, does not give any history of past seizures. And we do an MRI, we do blood investigations and an EEG, and we find nothing abnormal on EEG or MRI. First seizure, no obvious provocation, no drugs that could cause seizures. The question is, how do we manage this patient?
Okay, so just one thing is, sir, what was the age of the patient?
27, male.
27 male. Okay, so the thing is, whenever you've got such a patient come into the casualty, usually these patients need to get to the hospital. So one ground rule is that when you have these kind of patients coming to you, it is very important that they get to a hospital and you try to not manage them at home. Okay, so that's point one. Point two is there are certain guidelines about how to proceed with acute seizures. Okay, so one of the most important guidelines here is that there is a rule. Okay, and I have recently written like a ready reckoner where I have made it into like a 1, 2, 3, 4, 5 rule. So one blood test, which is mandatory. Okay, you cannot do anything before you do that blood test, and that is blood sugar. So anybody comes to you with seizures, the first thing you're supposed to do is take a needle prick. I mean, of course, but one blood test, which is blood sugar. But before we get to the blood sugar, there are the medicine which you can give 2 times. Okay, and that medicine is benzodiazepine. Now, a lot of you have been around practicing medicine for much longer than me, and I'm sure some of them in the audience have been practicing medicine for longer than I have been on earth. So earlier we had like really weird things going on. So we had the rectal diazepam, which was very effective, but just the whole idea of trying to get that inserted rectally while the patient is seizing, it's so scary. Okay. And then we had got IV lorazepam, but again the patient is seizing, and you have to somehow manage to secure an IV line and get the drug in. Okay. Now we had IM medications, but we know that IM medications, there is a lag between giving the medication and the medication actually acting. So now people like me are blessed because we work in an era where we have something called midazolam spray. It's very effective, extremely effective, and so easy. There is the spray with a nozzle. You have to just put the nozzle into the nostril and give 2 puffs. Very easy. Almost everyone can manage. Now, in so when this patient comes to the casualty, I think all casualties should be equipped with this spray, considering that he's still seizing. Suppose the seizure has come and gone, then you have time to secure an IV line. So again, so one blood test which is mandatory is blood sugar, because a lot of seizures are just hypoglycemia. Okay. Once that is done, then you have to check vitals. Okay. So pulse, BP, airway, your normal CAB does not change. So your circulation, airway, breathing. Once you are done with checking the blood sugar, you have given the loading dose of lorazepam or whichever which was your medication of choice. Then your next, what you have to do next is that you have to check for circulation, airway, breathing, make sure everything is fine. Now, these patients will always require an anti-seizure medication dose. Okay. And here I just want to put a point across about anti-seizure medications, which I talk very often with my patients, which is that anti-seizure medications are like paracetamol. All that they are doing is that they are stopping the seizure from happening, just like paracetamol stops the fever from coming. Okay. They are not some hi-fi drug that is going to change the morphology of the brain or make any difference to the pathophysiology of the seizure. Right. So the first thing you're supposed to do for this patient is give a broad spectrum anti-seizure medication. Now, one of the very nice broad spectrum anti-seizure medication, again available to me because I was born and practicing medicine in this era, is levetiracetam. And we have a running joke among neurologists that the current way of telling neurologists or MD physicians is that patient has a seizure, first give levetiracetam and then decide what you want to do after that. And actually, there is a reason why the drug has this reputation, because it is so safe. It can be given in anybody. You don't have to think. You don't have to worry. So yes, for an acute setting, actually, it is my favorite choice of drug. Also, you have brivaracetam, which works almost exactly like levetiracetam without the behavioral side effects. So, if you are comfortable with levetiracetam is a good drug of choice. If you feel that levetiracetam is not working for you, you want something more, you can go for brivaracetam. Okay. Now, once you have administered the intravenous medication, then the next step begins. Here, I would recommend that you first send blood investigations to check for electrolyte imbalance, check for liver function, check for kidney function. And at the same time, try and get history for alcohol intake. No alcohol intake for 2 to 3 days in a person who consumes alcohol all the time. Any illicit drug use, any substance abuse, any medications that have been given, to know whether this is a primary seizure, which is an unprovoked seizure, or a provoked seizure, which is more common. Okay. Now, once you are done with this history, the next step is about trying to know if there is an infectious cause. So you have to ask about whether the patient had fever, whether the patient had any other symptoms like nausea, vomiting, headache, etc., etc. Now, by this time, you have enough information. So you know the pulse, the BP, you know the history, and all of that. Usually, I would recommend a scan in patients with first seizures. Okay? Uh, if we do not get anything out of your initial information, or if the BP is high, or if there has been history of loss of consciousness and vomiting, or there is a clear-cut neurodeficit. So you find that one hand is not working, one leg is not working, there is hemiplegia, or there is a facial deviation, facial weakness. You are getting such weird history of behavioral abnormalities which doesn't fit into anything except encephalitis. So all of these things, see, it is important to take history and history fast. So if you are finding some reason, some very clear provocating factor, like you find hypoglycemia or a very obvious electrolyte imbalance, then okay. But if you don't find any of these, you might still want to go for a scan later on. However, if there is something very striking like a pupillary asymmetry, a very raised BP, a neurodeficit, any neurodeficit with a seizure, always get a scan done. In case
So,
of no neurodeficit, you can wait for it.
okay, so
Yeah,
there
go
is a
on.
chance that we will get away without doing an MRI in the first seizure if we don't find any precipitant. That's what I'm saying. And what about the EEG?
If
That
we
may
don't,
also be not done. Does an
uh,
EEG become
so
mandatory or not?
actually, once, yeah, I'll tell you what. Routine EEG, the EEGs that we do in practice, are of very less value once an anti-seizure medication has been started. Because if the
Got
patient
it.
has
Okay.
had only one seizure and never had any other seizure in his or her life, and you have started an anti-seizure medication, and the seizures are well controlled now, on that medication to find anything in a routine EEG is going to be very difficult. Okay, so what
We
you
have been
can do
taught.
here,
Yeah. Sorry. No,
so
sorry. I'll
what you
interrupt
can
you.
do here is,
Okay. No, we are lagging to each other.
okay,
I'll
so
take
what you can,
one second. You please carry on. Please carry on. What we can do here is
yeah, what we can do is that we can actually do a sleep deprived EEG where we ask the patient to sleep a bit less at night, because lack of sleep is a very important precipitant of seizures, and it is mandatory to do an awake and sleep EEG. Now, so many times we get an awake EEG which has absolutely no value. So you need an awake and a sleep EEG. Now, I
okay.
think your question was that you have been told that for a first seizure, you always do an MRI and an EEG,
No, 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 no,
which
no.
is actually not wrong.
Okay. No, I was. We were taught when I was young. At least that's what I remember. That you need two seizures which are unprovoked to put the patient on anti-epileptic
Yeah.
therapy for a long term. Is that right or is it wrong now?
Um, okay, so the definition of epilepsy is that you need two unprovoked seizures 24 hours apart, at least 24 hours apart, or one seizure with the likelihood of a second seizure being equal to that of a person with epilepsy. So, this second sentence is very important. So, what happens is that, patient comes in with a single seizure. If you feel it is a provoked seizure, you don't need to put the patient on long term anti seizure medications. For a provoked seizure, if you find that there is uh, a lesion or a place in the MRI from where the seizure is coming, then you might want to do an EEG to just confirm that there is no other seizure coming from anywhere else. Because that is also important. Because you have something sitting in the MRI, but maybe that didn't cause the seizure, something else caused the seizure, right? And again, symptomatic seizure therapy will be required for as long as the patient has the problem. Let's just take,
Okay.
for example, that the patient has meningitis. So, for as long as the patient has meningitis, you will have to give anti seizure medication, or the
Very good.
patient has encephalitis. So same. Or if the patient has something very benign like a dengue or a malaria, but till the patient gets better, you will have to give medications. In these
Correct.
people, what we usually recommend is you continue anti-seizure medications for a fixed period of time, 3 months or 6 months. Give them a drug-free trial, and on the drug-free trial, get an EEG done when the patient is drug-free. And if that
Correct.
EEG is normal, then the patient need not be on drug. Okay, but
Wonderful. Yeah.
again, the patient needs to know that there is a lot of risk of me getting a second seizure. So, when you are taking the patient off the medication, you have to be very clear medico legally that no driving, no going to heights, no going to water, and in Mumbai, especially, no traveling in local train. Because I'm always worried. The biggest fear that I have is one of my seizure patients is going to have a seizure while getting in or out of a local train, and that's going to be the end of it. So, at least for that period when you are hanging in between, not sure where you are, maybe avoid being in situations, taper off the medication, do an EEG. In
Wonderful.
any seizure, even if the patient has had one seizure, I will recommend a good planned, thought about EEG where you can get some yield about what is going on in the brain.
Correct. Uh, Most of us family physicians will probably be seeing more provoked seizures than unprovoked seizures. For the audience, provoked seizures are
Most
basically
people.
seizures which are precipitated by some event like metabolic event or infective event. So, can you tell us what are the common provocations of seizure or secondary causes of seizures that family physicians are likely to see?
Right. So one thing is very like clear here. Let's just make it a bit easy. So you have seizure classification, right? So the most common seizure that we all know about is the generalized tonic-clonic. Okay. Sometimes you will see clear focal motor seizures coming to you with one hand going like this, or with the face twitching. Okay. Very rarely, from the general physician perspective point, you will see a temporal lobe seizure. Now, a temporal lobe seizure is like, and I always use this analogy with my patients. You know this Amul girl, the Amul girl. Okay, so you see the Amul girl once, and then wherever you see the Amul girl, you know it's the Amul girl. You can't miss it. So the same thing is with temporal seizures. You see temporal seizures once, and then you know whenever you see them again, they are temporal seizures. So I'm just going to act it out a bit. I'm not very good at it. My seniors are really good at it. But what happens is the patient blanks out, so just stares into nothingness, and then the mouth starts moving. And then you're calling, Natasha, Natasha. And then there is this movement. This is called automatism. It can be anywhere. It can be like this. Let me like this. Both hands, one hand, any hand. And then sometimes one of the hands goes like this, just doesn't move when the other hands go. Calling, no response, no response. Sometimes there is no speech arrest. The patient is talking but blabbering, not really there. And then the patient comes back. And sometimes all of this doesn't happen and the patient is just staring into space. So these are often missed by family. Okay, but sometimes family members who are very smart might recognize them and get them to you. Now, temporal seizures happening secondarily is a little difficult. Majority of your secondary or provoking seizures are GTCs. Okay, so
Correct.
if the patient has a generalized seizure, then there is very high chance that this is provoked. Very high chance. The only people who get generalized seizures without provocation are the ones who have got idiopathic generalized epilepsy, and most of them they usually present in early adulthood. So somebody like 27 is very late for an idiopathic generalized epilepsy to present. So 27 generalized seizure, very high chance that it is provoked. Okay. Focal seizures, like the one that I described, the temporal one or the frontal one. You know, when one limb is jerking, what does that mean? There is the area which is supplying that limb, the cortical area which is supplying that limb, something is going wrong there. So focal seizures. So a very important point to remember here is that if you have a generalized seizure, and MRI is not that important. It's important, but it's not that important. If you have a focal seizure, and every time that the patient gets the seizure, the patient tells you, "हर बार आता है, same आता है, हर बार आता है, same आता है, हर बार आता है, same आता है," definitely get an MRI done, because there is one particular area which is firing, and if you get an MRI done, you're going to find something. Now,
Wonderful.
these generalized seizures, which are happening because of some reason, let's get to that. Okay, so patient getting generalized seizures, it is a very good likelihood that you will find something. Now, most important things are, of course, electrolyte imbalances. So, hypoglycemia, hyperglycemia. Nowadays, we see so much of hyperglycemia causing not seizures, but choric movements of one side of the body or the second. And it is not, see, for somebody who's a neurologist, saying things like tremor, chorea, hemibellismus makes sense. But if I'm talking to someone who's a non-neurologist, this sounds like total Greek and Latin. कि हाँ कुछ तो हो रहा है. And if the patient is calling you, हाथ हिल रहा है, how are you going to know whether it's a seizure, whether it is a chorea, whether it's a hemibellismus? So sometimes even hyperglycemia can cause these movements, which look like seizures. Okay, so glucose. Sodium, very important. I think everyone checks sodium, but hyper, anything going wrong with sodium, very important. Ionized calcium. Nowadays, this has become very important because you've got so many people on chemotherapy and other agents. So sometimes calcium metabolism takes a toll. So ionized calcium, another important, electrolyte. Magnesium, one more very important electrolyte that can cause your provoked seizures. Okay, so this is about
Exactly.
electrolytes. Any kind of encephalopathy can progress to seizures. So, what are the three important encephalopathies? The hepatic, the renal, and the respiratory. So, you have got respiratory acidosis or metabolic acidosis, you will get a seizure because of just the respiratory and metabolic acidosis and nothing else. Everything else is fit and fine. Elderly patients with reduced brain reserve get seizures because very rare, but they get very drowsy when they have a urine infection. And
Okay.
sometimes they get a seizure, not very common, absolutely not common, but drowsiness, yes. So, what happens is that the patient becomes very drowsy, does not wake up. Relatives can confuse it. So, try and look for urine infections. Now, something very, very interesting about urine infections is the drugs. So, if you're going to come to the drugs later, probably we'll hold it for now, but remember, okay, the drugs. Okay, so
I
we'll
agree.
discuss drugs. Now, there is encephalitis. Encephalitis is very common, and one of the forms of encephalitis which has become extremely common now is herpes encephalitis. Again, one of the reasons for herpes becoming common is immunosuppression. We all know, at least, even socially, you will know at least 10 people who are on some mild, moderate, severe level of immunosuppression for some or the other reason. Rheumatic disorders, immunological disorders, neurological disorders, cancers, chemotherapy, liver issues, renal issues, the list just goes on and never stops. So, herpes encephalitis has actually become extremely common. And remember that temporal lobe seizure that I described? Sometimes herpes encephalitis presents like that. Sometimes it just presents like a actual generalized seizure. And sometimes herpes encephalitis just presents with behavioral changes. So the patient's relatives will tell you there is just odd behavior, forgetfulness, weird behavior, we don't know what. So herpes encephalitis, and there is this new kid on the block which neurologists keep diagnosing everyone with autoimmune encephalitis. So autoimmune encephalitis is like this new kid on the block, everyone likes it. It is like the Zudio. Nowadays, everyone wants to go Zudio and buy clothes. So the way that, that's what you will think. But you know why we try to diagnose people with autoimmune encephalitis is because it's treatable and we are looking for treatable causes. Okay.
I'll
Now,
just clarify
there are
once for the
infections. Sorry?
Sorry, I'll just clarify for the audience. When you mention herpes encephalitis, she's talking about herpes simplex. So herpes encephalitis is not preventable by Shingrix vaccine. Just to clarify.
Yes, yes, yes. That's very important. That's a very important point. It is herpes simplex, not so. It's not the varicella virus. It is the HSV1 virus, which is not the varicella virus. So the varicella virus is preventable by the shingles vaccine, not the HSV. Yeah, that's a very good point, sir. So that, and in India, to be honest, I mean, there is all of this is worldwide. Everything that we discussed till now is worldwide. But especially in India, I think it will be very wrong of me to say this, but the two most common causes are not either of these. I mean, electrolyte imbalance, okay. But one of the most important causes of provoked seizures in India continue to remain till date neurocysticercosis and tuberculoma. So there is nothing, and out of some way, a neurocysticercosis happens and fires, and the patient gets a seizure. But in neurocysticercosis, you usually get focal seizures. So wherever the neurocysticerci is in the brain, if it is in the frontal region, you get a frontal seizure. If it's in the temporal region, you get a temporal seizure. Sometimes you're really unlucky, and the worm just takes over your brain completely. So there is a worm here and here and here and here and here and everywhere. So you get a generalized seizure. Again, tuberculomas and tumors. We see so many patients getting their first seizure, and then when you look at the scan, you are in shock. I mean, I have seen at scans like this. Literally, that's the expression on your face because there's no history of anything. The patient has a seizure, and there is a huge glioma staring at you in the face, and often these are glioblastomas. So one seizure and you are giving the patient this devastating news that this is a glioblastoma ho gaya. So sometimes, you can life can take you by surprise, and that is why the insistence for a scan, after the first seizure, the whole insistence for a scan is not uh, anything but this. And one more thing, I think we are very lucky in India, because there is so much of radiology available to us so easily. So it is so easy for you to go and see what is inside a person's brain. If you feel that a patient is not affording for an MRI, even a simple CT can give you a lot of information, at least basic information. So I feel we are lucky, and I feel we are lucky, so we should make use of the luck that we have and try and get scans for first seizures.
I'll request one clarification. You said that sometimes MRI may be skipped if the patient presents with generalized tonic-clonic seizures. But may I ask you if
Absolutely. Yes, sir. Yes, sir.
may I ask you if a focal seizure with secondary generalization may fool us because the patient may not have noticed
It
the
can.
focal onset.
Yes.
So okay.
Yeah, that's very
Uh,
much commonly seen. So in practice, sir, to be honest, like being very candid here, in practice, I am yet to see somebody who does not get a scan done. The
yeah.
only thing is, in case of a clear focal onset or a neuro deficit, it is an emergency. In case of a generalized where you're looking for answers, it's not an emergency.
Maybe. Okay. You were talking about drugs, and I'll just take that first. What drugs can provoke a
Yeah.
seizure, especially what outpatient drugs can provoke a seizure? Oral drugs.
So, not many outpatient drugs, to be honest, are like very seizure provocative. Certain medications which can cause electrolyte imbalance, I think everyone knows about them. So, you have got your diuretics which reduce sodium, or you have got certain other medications which cause tumor lysis. Drugs which cause tumor lysis can cause increased calcium and they can cause seizures. So, that's why I mentioned these. But I think the most important drugs that we need to talk about are antibiotics. Now, a lot of antibiotics which we give very routinely, extremely routinely, are known to be reducing the seizure threshold. Okay. So, now I want to explain very nicely what seizure threshold is. Okay. So, think of it that this patient is going to develop a seizure if the patient crosses this line. Okay. If this line is crossed, then the patient will get the seizure. So this is your seizure threshold. Now, what antibiotics do is they bring it here. From here, only if things go wrong up to here, the patient is going to seize. Antibiotics bring the seizure threshold down here. So, a patient who was not going to seize anyway will not have a seizure on the antibiotic. But a patient who has a substrate that makes him or her likely to seize, or is a known case of seizure disorder, or has had seizures previously in the past, this patient will definitely seize when you start that antibiotic. Okay, so this is very important to understand. It's not a cause, it is just bringing the threshold down from here to here. And the most notorious ones are not the outpatient ones, but the ones given in the ICU. So very classical example is somebody comes with a secondary seizure, provoked seizure. Okay, you find that there are electrolyte imbalances, there are kidney issues, renal issues, all of that, and the patient also has a urine infection. And the patient is given the favorite drug of all for urine infections, the panacea of antibiotics, meropenem. Patient is started on meropenem, infection is getting better, seizures are getting worse. Very common phenomenon, very common scenario in the ICU. So what do I do now? I stop meropenem. No, I can't stop meropenem because meropenem is treating the cause. Remember the first sentence that I said. What are anti-seizure medications? They are paracetamol, and that is why the name was changed from anti-epileptic to anti-seizure, because the medicine is not to the epilepsy. It is just stopping the seizure. So you step up the anti-seizure medication. If you are giving one, you give two. If you are giving a low dose, you give a high dose, and you continue the meropenem. But you should know that this can happen. so that when you start meropenem, your eyes and ears can be open. So other medications are meropenem, imipenem, piperacillin tazobactam, and all of your fluoroquinolones. Now, what are the OPD drugs which are equivalents of these? You are giving
Ciprofloxacin.
fluoroquinolones a lot. Yeah, you're giving fluoroquinolones, everyone gets. So any fluoroquinolone that you are giving to the patient, and some of the penems that we give now orally for UTIs, for drug resistant UTIs. So those drugs we need to be careful.
Uh, we are a little short of time, so I'm going to be have more question and answers in brief. Uh, the outpatient physician, the family physician, can they treat in their clinic seizures after establishing that there is no precedent? Of course, provoked seizures they can treat, but unprovoked, can they treat without the neurologist's help? And if they do start any treatment, what drug do they start?
Right. So all over the world, epilepsy is treated by the primary physician. So there should be no lack of confidence, I feel, because generalized epilepsy, idiopathic generalized epilepsy, epilepsy since childhood, temporal seizures, all over the world, these are being treated by general physicians. So my recommendation is very simple. The patient comes to you with a seizure disorder, make sure that the workup is clean. Okay. So an MRI with a harness protocol, which is the epilepsy protocol. Then you get a good EEG done. Make sure that the patient has visited a neurologist at least once. Okay. Because we need like a comprehensive diagnosis for the patient. So the patient has received a neurological consult, a diagnosis has been established. The diagnosis most likely in India could be either secondary seizures due to tuberculosis, neurocysticercosis, or infection, or primary seizures due to idiopathic generalized epilepsy, mesial temporal lobe sclerosis, encephalitis related, or something which we call remote symptomatic epilepsy, which means at some point of time the patient had something in the brain. This is also one of the questions, so I'm also answering that at some point of time the patient had a tumor or a neurocysticerci or a tuberculoma or something in the brain. Whatever the patient had went away, treated, but a scar is left, and that scar is causing seizures, which is called remote symptomatic epilepsy. Also, sometimes you have got children who have hypoxic or hypoglycemic insults, and they continue to have epilepsy. So all of these people who I mentioned can easily be treated. So do an MRI, make sure that the MRI and EEG are done, make sure that the patient has received one neurology consult, okay, and that you have agreed on what medication to be given for the patient. Once that is established, the patient can follow up with you regularly, and only if you see an increase in seizure frequency, or you see a new seizure phenotype coming in, like something which you didn't have before now has, only in these cases should you make sure that you get a neuro consult again. Otherwise, generally, you can treat the patient on your own. So, what you
I'll
need
ask
to
you.
know is two things. One,
Sorry, now
yes,
I
sir,
will ask
sorry.
you two pointed questions. If a patient is diagnosed as
Yeah.
idiopathic generalized epilepsy, what is your first choice drug in a female? What is your first choice drug in a male? And what is your first choice drug in an older male?
So, ideally, levetiracetam is a very good drug. We usually give levetiracetam now to everyone. There is nothing wrong with giving levetiracetam. There is nothing wrong with giving levetiracetam. Valproate is an excellent drug for idiopathic generalized epilepsy. There is nothing wrong with even mentioning that. However, there are many countries in the world that have banned the use of valproate, the most recent being the UK NHS, which has actually given us a whole, like they have literally banned the use of valproate, that you cannot use valproate anymore.
In the
For
childbearing
females of
age group or
reproductive age,
only females, right? Of
for
reproductive
females
age.
of reproductive age, so the guidelines have become so strict you can't give it. But let me tell you, valproate is an excellent drug for idiopathic generalized epilepsy. Okay, so do not strike valproate off your drug list. There are so many patients with idiopathic generalized epilepsy who will not respond to levetiracetam.
Mhm.
So what we usually do is we give levetiracetam, we see if the patient has responded or not. Responded, everything okay, so far so good, great. Levetiracetam has just one major, very important side effect. It makes young men very aggressive and it makes older men very drowsy. I don't know why it does different things at different age groups, but this is the truth. So, if your patient is extremely aggressive or extremely drowsy, then you need to change the medicine. There is no way that the patient can continue. Sometimes even young people become drowsy. So, drowsiness and aggression, these are the two. They are on different ends of the spectrum, but they are two very important uh, side effects of levetiracetam. The side effects of valproate, obviously, everyone knows. I don't need to repeat them. But yes, valproate is teratogenic. Eptoin is teratogenic. So phenytoin and valproate are both very, very teratogenic. Uh, Phenobarbital is also teratogenic. Some newer anti-seizure medications like topiramate, that topiramate is also equally teratogenic. So we have got a lot of teratogenic medications. Females of reproductive groups stick to levetiracetam and a new drug called lamotrigine. Lamotrigine is a sodium channel blocker and it works now. It has been approved for giving as an independent drug even for idiopathic generalized. So you can also start with lamotrigine. There is just one problem with lamotrigine. It causes skin rash. So with lamotrigine, you can't start with a high dose. You have to go up very slowly. So the usual practice is to give some other medication, add lamotrigine to it, slowly go up on the lamotrigine to reach a dose where it fits the patient. By the way, lamotrigine is an excellent medication. Not only does it control seizures, it is a mood enhancer. So it works so well because patients with epilepsy have mood problems. Only problem is rash. And I have also seen an SGS due to lamotrigine. So it is not किसी को रैश नहीं होता है ऐसे ही बोलते हैं. I have had an SGS because of lamotrigine. And SGS is like the patient either lives or dies. So it's a serious condition. Always educate your patients about the rash. And as a doctor, always mention it in your prescription paper. This drug can cause rash. Stop drug immediately if rash occurs and report back immediately in case of rash. If you give valproate and lamotrigine together, they are synergistic. In case nothing else is working, this is a very good combination and can be used. So this is for IgE. Usually, I think now we use levetiracetam, lamotrigine, or if required, we put valproate into the mix.
What is your drug of choice for focal epilepsy? Say, for example, a cystic circus related focal epilepsy.
Yeah. So focal seizures, carbamazepine, oxcarbazine should be the first drug of choice. Do not start levetiracetam. See, levetiracetam is broad spectrum. It will work for anything. And so is valproate. But carbamazepine or oxcarbazepine in very low doses are very useful for controlling focal seizures. So you will not have to escalate on the dose. Your side effect profile will be good. And the drugs are good controllers. So we still go with them. Lamotrigine can also be used. If you attend a few abroad meetings nowadays, they are completely shifting to levetiracetam, lamotrigine from away from all of these drugs. But I will tell you this that I have had patients. Yeah, I have had patients with partial seizures who do respond really well to carbamazepine. These drugs are not very expensive. I know that we shouldn't bring this up, but come on, we are in India. If you give a medicine to a patient who has to take the medicine twice a day, every day for the rest of his life, cost is an issue. So carbamazepine, oxcarbazine work well. Carbamazepine can also cause SJS, but there is a blood test. It's called HLA-B1502. This is a blood test that you can do. It is an expensive blood test, but you can do this and find out whether the patient is going to get rash due to carbamazepine or not. And it is a very effective test. It is available in all laboratories now. It is called HLA-B1502. Okay. So that oxcarbazepine, try to not give in elderly. I'll tell you why. It causes hyponatremia. And elderly is already at a risk of hyponatremia on one diuretic or two diuretic. Plus you give oxcarbazepine. Two things the patient's relative will call you next day. चक्कर आ रहे हैं और गिर रहे हैं. Now this chakkar aa rahe hai is a side effect profile which we call the sodium channel side effect profile. So what are the drugs which are sodium channel inhibitors? carbamazepine, oxcarbazepine, phenytoin, and lacosamide. So lacosamide is also a new drug we use usually as a second add-on. Okay. Now what happens is sometimes it is not controlled on one drug. Partial seizures, focal epilepsy, not controlled on carbamazepine or oxcarbazepine. Second add-on you add lacosamide. Good drug. Lacosamide is a good drug. Lacosamide has two problems. One is sodium channel side effects. Other is ECG. Sometimes it causes prolongation of QT, prolongation of PR. So again, in elderly, be careful. Okay. Now, these sodium channel drugs, if you give two of them together, the patient will start feeling giddy. There will be a bit of a nystagmus. The patient will feel like the patient is falling all over the place, and plus sodium will go low. So be careful. With oxcarbazepine, always be careful of sodium. It's a very important problem. And be careful of not giving two sodium channel drugs together.
So you've talked about
But otherwise, yes, carbamazepine,
good.
and then levetiracetam.
You spoke about idiopathic generalized epilepsy. You spoke about focal epilepsy. What about complex partial seizures or temporal lobe epilepsy? What drugs are the drugs of first choice?
So they are also kind of focal epilepsy. Yeah, they also fall into the criteria the same as focal epilepsy. So same.
Okay, great. When should a GP refer the patient to the neurologist? When two drugs fail or when the first drug fails? Two drugs.
So see, I think it really depends on how confident you are with your medications, how well you know your drugs. Okay. It is not a one size fits all solution. What I will recommend is that be good friends with a neurologist. When you have a patient coming to you for the first time, send the patient once for a diagnosis. Send the patient. We do send patients back because there is really no fun in sitting and doing CT all. I mean, it is really no fun. Now, usually, when one drug fails, you have to try and understand why that drug failed. Okay. And this is worldwide. This is not an India specific problem. You need to find out if the patient is taking a medicine every day. I think some of you are at that age where you take medicines every day. But I'll tell you my personal experience, just having to take vitamins during pregnancy was such a big deal to me. It was so difficult. You have to take the medicine every day. You have to take it at a specific time. You cannot miss. Very difficult. So, anti-seizure medications have to be taken 12 hours apart, preferably at the same time daily, and you should not miss them.
Okay.
So, first thing is find out drug compliance. Second thing is find out about what are the things which can precipitate seizures despite taking drug on time, not sleeping. So, I have a mentor who has been my mentor for a while, and he says this: sleep is an anti-seizure medication. If you don't sleep, there is one medication which you are taking. So please say this to all your patients. Epilepsy patients cannot not sleep. They have to sleep. They have to miss parties. They have to not drink. So no alcohol, no drugs, and sleep is very important. And just on the topic of sleep, one of the newer causes which have come into light recently of new onset seizures and especially nocturnal seizures is sleep apnea. So if you have a patient who you think might be on might be sleep apneic, you have to try and solve the sleep apnea part.
Wow.
So sleep apnea is a different topic. We can talk about it on some other day. But remember that sleep apnea can also cause seizures. It is one of the most important causes of new onset seizures in an elderly patient. So always remember that. Okay. Now, what you can do, yeah, it's very important. I think if an elderly patient comes to me, new onset seizures, first time in life, never had seizures before, the first question I ask the spouse is, रात को खराटे लेते हैं क्या? हाँ, खराटे लेके उठते हैं क्या? हाँ, आप पहले sleep study कराओ, बाद में बाकी का सब. So sleep apnea is an extremely important cause, should not be missed. So once you are done with all this, that means it's a true recurrence, okay, of seizures. It's really true resistance. Now, the definition of drug-resistant epilepsy is that when two appropriately chosen and adequately dosed drugs have failed. So the second line, the first line you will appropriately choose. You might call somebody, say if this is the right choice, not right choice. Second line is equally important. Adequately dosed. Do not underdose your patients. So try and find out what the correct dosage is for a medicine and try and stick to the correct dose. Because if you underdose, it will be a problem. And the real thing in India is that most patients do not weigh 70 kilos. How many of your patients you see are actually 70 kilos? We see patients who are 80, 90, 100. Dose them accordingly. Somebody is 50 kg, you give them a 50 dose. But don't give a 100 kg person or a 90 kg person a dose that is meant for a 50 kg person. So
Absolutely.
make sure that you choose correct, make sure that you dose correct. And then if it is still not controlled, obviously you have to refer to a neurologist or a person who is dealing with epilepsy patients more frequently.
Wonderful. Can I have the first slide PPT, please? Uh, Dr. Namrata or somebody there? First PPT. I'll just show them some slides that you have shared with us. Uh, uh, those. Please talk about
Sure.
these slides very briefly, if you can. This is Dr. Natasha.
Yeah, so
If you can
the
just.
thing is, this is probably yeah, sir. So these are normal MRI images. There is often this question, just quickly saying this, that there's often a question about what MRI to do, how to do an MRI. So a normal 1.5 Tesla MRI is good enough to pick up most problems. Okay, so you don't need to go ahead with the 3 Tesla the first instance itself. You get a normal 1.5 Tesla MRI done, a normal brain MRI, preferably always with contrast for epilepsy or seizures. Always prefer to do it with contrast, unless creatinine is an issue, whatever. But always the one thing which you should write is MRI brain with contrast. And in some patients, if you don't get anything on the 1.5, then get a 3 Tesla harness protocol MRI done. But that is for people in whom 1.5 did not show anything, not for everyone. Okay.
Harness is a
So
special
this slide is
protocol
showing
for epilepsy. Harness is an
for
epilepsy
epilepsy.
protocol. Okay.
It's
Okay.
an
This slide is
epilepsy
showing.
protocol. Yes.
Yeah.
So it is very clearly showing tuberculomas. Now it could show NCC also. The reason why it is not NCC is that huge thing which you see right in the middle. It is looking like more this thing. This looks more like a tuberculoma.
Okay. Okay.
Yeah. So this is a very common thing that.
Next slide, please. I don't know if I can operate the slide, but somebody can help me. Yeah.
Yeah. No, no, it's okay, sir. So the earlier slide was a tuberculoma. This could also be a tuberculoma. Why is it not a tuberculoma? Looks similar, no? Why is it not a tuberculoma? What you see, all the white that you see is actually edema. It is not, the lesion is just this. Okay, the problem is just
The
this.
small
All
area,
the
the
white
circular
that you
area is
see
a
is
lesion.
edema.
Hmm.
Yeah, and all the white that you see is the edema, and in the middle of all the black, you see a small white that is the worm.
That
So
is
that tiny
scolex.
white
That,
in the middle
that
of the
we call
black
the
is the
scolex.
worm. So basically, easy way to say is it's the worm. So
Worm.
this
Yeah.
is why this is NCC and not T. Now,
Okay.
I'm just putting this across. It is very difficult to differentiate NCC from TB. Even the best MRI centers cannot do it sometimes. Okay.
Okay.
So don't be very hung up. And one thing which can help is getting a spectroscopy. If you are in a center where spectroscopy is available to you, spectroscopy can help to diagnose tuberculosis versus NCC. Also, if there is not much of an edema, then eventually, once the edema settles, you can do a lumbar puncture and that can also help.
Okay. I'll take the next slide. This
So,
patient
this
came with
is
a
the horror
frontal lobe
situation.
seizure. Yeah.
Yeah, this is the horror situation that I was talking about earlier. It is genuinely a horror situation. And trust me, there are no other findings. So it's clearly a mass, very, very clearly a mass. Most likely a glial tumor could turn out to be a glioblastoma. These horror stories actually happen. So be very careful with these horror stories, and that's why we insist on getting scans done. Yeah, so this is actually one of the other conditions that we discussed. And See, for somebody who's not used to seeing MRIs, this might be a little difficult, but if you compare the two sides, one side is whiter than the other. Now, of course, this is a representative image, which is why it is so clear. It's usually not this clear, but any good reputed MRI center will tell you that there is a hyper intensity in the mesial temporal lobe, and that should be enough reason to give acyclovir. Again, I am very fond of acyclovir as a medicine. It is, unless you have a renal problem, in which case all you need is a dose correction. Acyclovir does not have a lot of side effects. I mean, if you have a renal problem, you'd give dose corrected for renal problem. And if you have a patient who is getting seizures, you're not sure, herpes is not always so apparent. You know, herpes is one of the masqueraders in medicine. Herpes is that mischievous boy that goes everywhere and does all the mischief, and you don't know who caused it. So, always a good idea in patients with meningitis or encephalitis or seizures where you're not quite sure what is happening. Giving acyclovir is always a good idea. The other problem is that the test for herpes is a bit expensive. So, this is purely practical. Often at times I'm asked, can we skip the test? You should not skip the test. But if you are in a really resource poor center where the patient can afford either the test or the acyclovir, like, you literally have to choose either test or acyclovir, then do acyclovir. That's what I would like to say. Now, this is what we were talking about, remote symptomatic epilepsy. Okay, so we spoke about remote symptomatic epilepsy where something happened, it went away, and now the patient has epilepsy. So something happened on the right side, your left, right of the patient, of the brain to this person. It's finished, it's gone. It could have been an encephalitis, it could have been an infective encephalitis, whatever it is finished. And now the patient is left with a shrunken brain on the right, your left, patient's right. Patient is left with a shrunken brain, the other side is good. So this brain, which has shrunk in size, has become gliotic. When anything becomes gliotic, there is always a chance that the seizures will start from there. So that is what this MRI shows. So this is also secondary to something that happened. Now this time it is the left of the patient, your right. That black area which you see left of the patient, your right. This could be an infarct, it could be a bleed. Most likely it's a bleed, considering the area where it is. So something happened and went away. Now the patient is left with no brain. So this area will give rise to seizures sometime. You have to be careful. And this is the mesial temporal lobe sclerosis that I was talking about. Very difficult, very difficult. But I have tried to get as descriptive. Never will you see an MTS like this. Never. MTS is very subtle. But if you see patient's right, your left is the temporal lobe, which is located right in the bottom. I don't know if my pointers are visible, but right at the bottom, after the ventricles, if you go and draw a horizontal line, you can see the temporal lobes. And patient's right, your left, there is a big black hole. And on the right, on the left of the patient and your right, that black hole does not exist. So basically that area got gliosed. So this is like temporal sclerosis following gliosis.
That was the last slide. Again, as we're short of time, we'll quickly go to the questions. Should I take the questions or will Dr. Sayali help us or Dr. Namrata? Who is here?
Can I just say one thing? Can I just say one thing before we end? Because we are on this slide. Okay. So especially this slide and that glioblastoma slide. Okay. I just want to say that sometimes the treatment for epilepsy is surgery. And especially this slide is your ideal surgical candidate. Right temporal, mesial temporal sclerosis should be operated because there is no risk. Left side temporal lobe has speech, it has memory. We operate left also. But what I'm trying to say is that mesial temporal sclerosis is a curable disease. Do you know, like, curable? I'm not controlling it. I am curing it. So mesial temporal lobe sclerosis is a curable disease, and the cure is to do surgery and take that area out. If you have a tumor, The cure is to do a surgery and take that area out. So mesial temporal sclerosis, focal cortical dysplasias, dysembryonic tumors, all of these can be taken out and the patient will never cease ever again in their lives. So this is very important because in
You
our country, epilepsy is lifelong. So just remember that there are surgeries that can be done for seizures. Just keep this in mind and contact your neurologist for that.
you were saying that vagus nerve stimulation is also a form of therapy. What is that?
Yes. So vagal nerve stimulation. Yeah, yeah. So sir, vagal nerve stimulation is a new technique. It's something which we don't even open the brain. We basically stimulate the vagus nerve. But so see, most of the epilepsies where we can find something on the MRI, we can locate it and we can remove it. Suppose there is nothing on the MRI, or suppose the problem on the MRI is on both sides of the brain. Okay, one side and second side. Sometimes in patients who have hypoxic insults, hypoglycemic insults, in these patients, one of the surgical options now is vagal nerve stimulation. So, vagal nerve stimulation is not a cure. This surgery is a cure. Vagal nerve stimulation is a way that we are adding an anti-seizure medication. But it's a very effective one because vagal nerve stimulation is known to reduce the frequency of seizures by more than 60 to 70% in really difficult to control epilepsies. So when I say really difficult to control, I mean people who get 4 seizures, 5 seizures in a day, their seizure frequency really goes down with vagal nerve stimulation. So even beyond surgery, now we have something that we can help the patients with. And just we have a few more drugs that have come into the market. You will be seeing these in prescriptions as general physicians. You will be seeing a medication called perampanel. Perampanel is a very good drug for encephalitis related seizures. So herpes
Okay.
encephalitis, autoimmune encephalitis, all of these, perampanel is a very good drug. Lacosamide I already spoke about. Lamotrigine we have already spoken about. There are certain pediatric drugs, not what needs to be discussed. Clobazam has been there for a while, but clobazam is a very good drug which you can give patients when their seizures are going up and down. And yes, cannabidiol is approved for treatment of epilepsy. Right now, the approval is for childhood epilepsies, but very soon we will get adult approvals. So, if your patient asks you, can cannabis be used? Yes, but not the cannabis that you will buy and use it. There is a cannabidiol prescription. There is a nice bottle, a medicated bottle in which cannabidiol comes, and there are certain patients which whom we can give cannabidiol. So this is important to know because people will ask you कि
Correct.
cannabis दे सकते हैं क्या? नहीं दे सकते. Cannabidiol दे सकते हैं.
Correct. Two recurring questions that have come. One is, what happened to our good old phenytoin and phenobarbital? Have we not? Have we stopped using
So
them?
no, so nothing happened to them. Actually, phenobarbital has made a giant comeback in the world of
Oh,
epilepsy in the treatment of status epilepticus. So this is not a neurology forum, so talking about status epilepticus is a little difficult and we have lack of time as well. But
correct.
phenobarbital has made a major comeback as a drug that you can use when your primary drugs, and now the primary drugs are levetiracetam, phenytoin, valproate. If your status epilepticus is not controlled with levetiracetam, valproate, phenytoin, now we are giving phenobarbital, and it is a major comeback. Yay! Phenytoin has been replaced by its brother fosphenytoin, which is easier to administer because phenytoin had a lot of administration issues. But to be honest,
Again,
I
she's
think the
talking
drugs are
about.
very harsh on the central nervous system.
Yeah. You're talking about IV drugs. What
Fosphenytoin,
IV intravenous?
IV
So
drug,
what
oral, yeah.
about oral? Any
So
role of oral
IV,
phenytoin?
think, yeah, I was just coming to that, sir. So definitely roll in IV, okay? Because, and I will tell you, phenytoin is very useful when the patient has a kidney problem and you cannot give IV levetiracetam. Now you
Correct.
have very few drugs to give IV. So we give a lot of IV fosphenytoin to patients who have kidney problems and levetiracetam cannot be given. Okay. Orally, these medicines are very harsh on the brain, extremely harsh on the brain. And I don't know if you have seen the amount of cerebellar atrophy that happens in a patient who has been on Eptoin let's phenytoin, phenobarbital, or valproate even. If you just see their cerebellums, they are left with wisps of cerebellums at the end of 25, 30 years. Now, if you don't have any other medicine, it is better to lose a bit of your cerebellum than to lose your brain. So, if you don't have any other medicine available, if the patient cannot afford anything else, if you are in a really resource poor center and nothing else is available, yes, give phenytoin. No problem. No epilepsy is still better than, like some drug is better than no drug. But if you have even the slightest of availability of medications, I mean, levetiracetam tablets have become so cheap. Levetiracetam is now available in government hospitals, at least in Maharashtra, in Mumbai, where I practice. Government hospitals give you levetiracetam, and they have been giving levetiracetam for 10 years now. So I think valproate before phenytoin, unless phenytoin and valproate both are teratogenic. So valproate before phenytoin for sure. There is no need to cause that patient so much of cerebellar atrophy, unless there is no other way out. Gum
Last
hyperplasia. I don't know. The side effect profile is
too much,
too large.
too large. Last two questions. One is in idiopathic generalized epilepsy, when do we stop therapy? After how many years?
In IT, never would be the correct answer
Never.
here, but patients usually want a drug free trial. Patients always want a drug free trial. So, international criteria is 2 years of seizure freedom on medication. We taper drug. After tapering drug, we stop drug. After stopping drug, if the patient gets a seizure again, so you tapered the drug, you stopped the drug, patient had a seizure, you never taper drug again. But if you taper drug, you stop drug, patient did not have a seizure, okay, fine. Do an EEG and see. If the EEG does not show anything, you can be off drugs. So
And then
2 years, but 2 years the patient has to be completely.
last question from my side. Many people have asked about hysterical seizures or what we call psychogenic seizures.
Very,
How do you
very common.
diagnose? Sorry?
So very common.
Very
They are
common.
extremely, they are so common. Okay. And I just have a request here. Hysterical seizures mimic temporal epilepsy very closely. So
Okay.
although hysterical seizures are very common, do not always label women who come with those kind of seizures as hysteria. Please make sure that you give them a chance. Like the problem in India, especially, is that women who come with headache, back pain, and seizures are just not given a chance. So the first thought in your mind is पक्का कुछ तो साइकाट्री की होगी बट देखता हूं. नो, psychiatric or hysteria is always the last option. Even if your antenna are screaming at you, you have to evaluate a patient with hysterical seizures. What if it is syncope? What if the patient is falling because of syncope? Cardiac evaluation has to be done. Anybody who falls due to a seizure, or anyone who has seizure in standing position, always needs to be evaluated for a syncope. So, standing
Correct.
position. Somebody is asking the question as we speak. A seizure when you are standing up, upright, or you are sitting. A seizure with urinary incontinence can still be syncope. So, cardiac evaluation is very important. Any seizure in standing up, patient gives history, khade the, gir gaye. Always think of syncope. So, what do you do for syncope? You get an ECG, you get a 2D echo. No, that's not enough. Unless you get a 48 to 72 hour Holter, you're never going to catch an arrhythmia ever. Trust me. So please get Holters done. I have had the experience of catching an arrhythmia on a 7-day Holter, which was missed on two 48-hour Holters. So always
Yeah.
get a Holter done for your thought process whenever you are thinking of syncope. Now, the patient's seizures are clearly hysterical. Okay, you come with the patient's relatives comes with a video, and you're very sure that this is hysteria. What can you do? So this is what I usually do. I stop the anti-seizure medications because patients always come with some or the other anti-seizure medication. So what I do is that I stop the anti-seizure medication, and Then I get done what we call a video EEG. Okay. So what is a video EEG? It is a setup. So first you stop anti-seizure medication, because otherwise you'll be in a lot of dilemma whether what I'm doing is correct, what I'm doing is not correct, all of this. So you stop the anti-seizure medication, and then what you do is that you call the patient in for a video EEG. You start the EEG recording. So, what is a video EEG? A video EEG is when you put the EEG electrodes, the EEG is recording. Okay, that EEG record is going on, and there is a live video camera which is video recording the patient. Now, you have to really pray to God and hope that the patient has a seizure. So, how will a patient have a seizure? So, usually patients with hysteria, some are very smart, but the ones that are not so smart, there are certain triggers, or you can use certain methods. So, you ask them to hyperventilate and you give a positive suggestion. अब आपको फिट आने वाली है, अब आप सांस ऊपर नीचे लोगे तो फिट आने वाली है. Sometimes we use vibration, we use a lot of things. Okay, and we try and induce a seizure. Now, the most sure shot way to diagnose a PNES or a hysteria episode is that you do all this, the patient has an episode, but the EEG is not showing anything. Then you can be very, very, very clear that, okay, this is psychogenic non-epileptic seizures, and I do it myself, and a lot of centers do it. So this service is available. You might want to avail of it.
Okay, so Dr. Nathapnis, thank you very much, and we'll end the lecture with the take-home messages that you gave us. Can we have the second PPT, please? And it was really, really very helpful, Dr. Natasha, to have you here. And I hope we can, because this was not enough of epilepsy, of course. Okay, so there are some take-home messages that Dr. Natasha has chosen. First, she said that history is probably very important, and here we have a statistic that history can diagnose the specific form of epilepsy 50% of the times, while EEG can only probably do it 30% of times. Then, of course, she said about the definition of epilepsy: two unprovoked seizures 24 hours apart, or one unprovoked seizure, and the strong possibility of further seizures. For example, through an abnormal EEG, if we find, then you know that there is a strong possibility that this is epilepsy. She said about electrolyte imbalances, urinary tract infection, sleep apnea as important causes of provoked seizures. She spoke of harness protocol. I myself do not know much about harness protocol, but yeah, she said that it is a specific sequence. And as you know, if you know about PT-INR, we have international normalization ratio in PT-INR that standardizes the prothrombin time across laboratories. So harness protocol kind of standardizes MRI for epilepsy across various MRI centers. She says that cystic sarcosis remains extremely common, and of course tuberculosis. Here, there was one question that I must ask you. You said once that autoimmune encephalitis is a growing diagnosis amongst neurologists, and
Yes.
principally because it is treatable. Can you tell us how is it diagnosed and how is it treated, very briefly?
Autoimmune encephalitis is diagnosed by taking a CSF sample and sending it for studies. Most of the antibodies can be caught on CSF analysis. Some of the antibodies that cannot be caught on CSF analysis, for them, we look for surrogate markers like increased protein in the CSF. But so if you have increased protein in the CSF, your antibody may or may not come positive, but we always treat it. Autoimmune encephalitis is treated with steroids, injectable methyl prednisolone given for 5 days. If it doesn't work, second line of treatment is IVIG. If it doesn't work, third line of treatment is tocilizumab. And somebody asked about adalimumab. Yes, adalimumab is also used. So tocilizumab, adalimumab are third line. Along with that is, of course, rituximab. Rituximab is the new steroid and everyone loves it. So rituximab can also be used.
Thank you. Hysterical seizures, or better known as PNES, psychogenic non-epileptic seizures, as you said, can be diagnosed using a video EEG combined with the video combined with the EEG. Many people asked about pregnancy, and here is a repetition. So, levetiracetam and lamotrigine are the drugs of choice. Correct. I think
So just, sir, one thing. Oxcarbazine and carbamazepine can be used in pregnant women. It is not like they cannot be used. Okay, so there is not much of data that says that they are teratogenic. They can be used. Second thing, if a patient has crossed the third month of pregnancy, there is no point in changing the anti-seizure medication unless it is something very gross, like phenytoin or valproate. Even that, in a rural setup, you first do a USG, you see if the child is, because there is nothing that is worse for the
In the
child
seizure.
than a mother getting a seizure when pregnant. Okay. So, all of this is in the first trimester. So, try and make sure that known epilepsy patients have planned pregnancies. And even if they are unplanned, they come to you the minute UPT is positive. So, this is important. And all medications doses will increase in pregnancy because weight goes up. Remember, all anti seizure medications are weight dependent. When weight increases in pregnancy, your dose needs to be increased. So that is just two important things.
And lastly, as you said, any patient who is not controlled on two appropriately drugged and appropriately dosed seizure medications has drug resistance, and these patients have to go to a neurologist. And I will skip this. And you spoke about vagal nerve stimulation as a neurosurgical modality. Thank you again, Dr. Natasha. Wonderful, wonderful lecture. Thank you so much.
Thank you so much. Just can I just take 1 minute? There are some things which I can quickly say from the
Comment.
questions.
Yeah, yeah.
Resource poor, always use whatever is available. Whatever you have, status epilepticus is an emergency, controlling seizures is most important. Resource poor, use whatever resource available. No MRI, use CT scan. No drugs, use phenytoin, phenobarbital. Anything that is available is best. Gabapentin, pregabalin, not commonly used in seizures, mostly not used in seizures. 3 to 5 years, anybody who has been drug controlled for 3 years, 5 years, 6 years, give the patient a drug free trial, but make sure that the patient is aware of what they are getting into. Yeah, so I think this was some of the most recurring questions. And please, I would request the audience to read about just two drugs if you can, just two of the new drugs, lamotrigine and lacosamide. They are both very good drugs. A lot of questions that have been asked, they can be answered with lamotrigine and lacosamide. So, and last but not the least, if your patient resource poor is on phenytoin, valproate, phenobarbital, what can you do for the patient? You cannot prevent the cerebellum from going away. But what you can do is give calcium, give vitamin D, give folic acid,
Nice.
and make sure that the B12 levels are well maintained, and make sure that the iron levels are well maintained. This you can do. So give calcium, give vitamin D, give vitamin B12, give folic acid, give iron. That is good enough.
Wonderful. Thank you so much. You deserve an applause and hope to see you again. Thank you.
Yes, sure. Thank you. Just can I, somebody just asked frisium use. I mentioned about frisium. Clobazam is used usually as an intermediate medication when your seizure medications are not working. So use it at night, and whenever you feel that the patient is uncontrolled, put a small dose of clobazam 5 mg at night. Okay. Thank you.
Wonderful.
Bye. Night, everyone.
Bye bye.